So, speaker tonight is Kendra. Did I say it right this time? Kendra?
Yep, it's Kendra, just like Sandra with the K.
Okay.
It's a tricky one.
So Kendra's actually having knee surgery in a week, so it was hard for her to get out here from Illinois. But in the meantime, who is Kendra? She's creator and CEO of TIPS Medical Billing, which focuses on medical billing as a gateway to the dental medical collaboration. Having been a successful executive coach for one of the nation's largest practice management companies and having worked in the dental industry over 30 years, she is a hygienist in many different roles. She is a sought after coach and will ensure successful implementation of medical billing into your practice. So without further, we have Kendra. Kendra?
Yes. Can you all hear me okay?
Yes.
Excellent.
I'm gonna mute our mic unless someone has a question, so there's no feedback.
Sure. And I'm open to taking questions during the program, as you know, as well as after, if it's appropriate, or you can easily do that.
Perfect, thank you. And if anyone is, actually, if anyone has questions that they are on Zoom, it's probably gonna show up on your screen also.
Yeah, I'm not sure if it will. I
Okay.
don't see the chat box on my end.
Okay, I'll look for it.
So
Okay.
perfect. All right. All right. Well, thank you so much all for having me, and thank you for taking your evening out, because I'm sure this seems to be a really busy time of the year with kids going back to school, and I don't know, just weddings and all sorts of activities. It seems like fall's a busy time. So thank you for taking your evening out to come and listen and learn. I am all about interaction. So if you want to speak up, let them know there, and feel free to ask questions as we go along. I think that's important. If you're thinking something, somebody else is likely thinking the same question. So we all learn from that. I do want to, let's see if my clicker is going to work. Maybe not. I do want to disclose, I do have carry free and care credit in my presentation. They do sponsor me. However, they are not sponsoring this event. And also, obviously, the disclosure would be that I do own and am the founder and creator of TIPS Medical Billing. So you will see that in the lower left-hand corner on all my slides. And yeah, I think that's about it. So why did I do this? I've been in hygiene I graduated in 1993. I was a dental assistant prior to that while I was going to school. And I was taken out of my career back in, I don't know, 12 years ago, about due to a ski accident. And at that time I went into practice management, and I really found medical billing intriguing. I had attended a course 4 different times by the same doctor, and 4 different times I was still fairly lost. I had a better concept of what it was and how you could maybe do this, but what I saw really was the gap of how do we implement this into our practices? Because what I was hearing from the practices that I was working with and coaching with was, we've tried this, it doesn't work. So there came the opportunity to build out my company, TIPS Medical Billing, to try to close that gap. As a hygienist, early on, I already knew systemic oral health before it was ever being talked about, because I was identifying it all the time in patients, and seeing, if I did my SRP, my periotherapy, and they didn't get healthier, there was something wrong internally. And from that, it just grew. My knowledge just grew, and I identified more and more systemic conditions on patients. And so I really resonated with this whole concept of medical billing for dental, because we are so much more than just dental providers. We really are oral health physicians, oral physicians, whatever you want to call yourself. I think we minimize what we call ourselves. People don't, people, when you hear dentist, um, one, it screams teeth, and that's not what we're about anymore. And the same thing with hygiene. I do not like the term hygienist, because I feel like it too is just doesn't describe really what we do. So we're oral health care providers. And I really wanted to get in this because I really wanted to see patients get support. We all know, you all know, that the benefits for dental have only decreased. They haven't changed since the 1960s. And how can how can we continue to get patients off a 5-year treatment plan with just dental benefits? It's not going to happen. So obviously their systemic health is going to continue to decline. And so I really got into this with a patient-centric approach. And my goal for you would be to, if you incorporate medical billing into your practice, it's to start getting testimonials like this, testimonials from patients about how it changed their life and how you were able to get their treatment covered. I don't think my practices do enough of this, do enough of getting patient testimonials, but they're incredibly powerful. And it speaks volumes, and it's a great way to market. So it's something to think of as an end goal as to why you would want to do this. It's, I've always felt if we do the right thing for the patient and excel on that, I mean, without the patients, we don't have a practice. So we do the right thing for the patient, and the practice growth will organically happen. What I see, and what I've seen it change, I think it's gotten better, is that there is still a huge divide between medical and dental. There's no question. In that, we're still sitting out here on our own little island. And I would love to see us join and collaborate more with medical. It's happening. Sleep has forced that. And so that's good, but we're still a long ways away. I have seen progress over the last 6 years, 7 years, but we're still a long ways away from being truly united. And in that it doesn't really make any sense to me. My hometown is Red Wing, Minnesota. We grew up, my mom still goes to the Mayo Clinic in Rochester, Minnesota. And back in 1910, the Mayo brothers were talking about, this phenomena of, the mouth is the gateway to the oral health. So why is it that it's 2023 and we are still so far behind the 8 ball on this collaboration? Doesn't make any sense to me. The longer I do this, I truly don't understand. When we look at our bodies, I mean, there's 70,000 miles of vasculature. We pump over 2,000 gallons of blood per day. How in the world, if there is microorganisms, there's bacteria, biofilm, all of that, if the blood's coming out of the gums, the bacteria is rushing in. So how can we say that there's not a connection? And I think we know that pretty well in dentistry, but it's still not well known in medicine. If you've ever heard of Dr. Bradley Bale and Amy Doneen, they have they're big proponents of the heart attack gene, beat the heart attack gene. They have a new book out that talks about brain health and heart health as well. And really looking at those root causes of why are people having heart attacks, and what causes that inflammatory response. And, after taking their course and them guaranteeing 100% that if you're in their care, they guarantee 100% that you will not have a heart attack or stroke. But what they have done is they have incorporated dentists, our profession, into the mix, because they understand that there is a huge correlation between heart attack and stroke with the oral health. So I've learned a ton from them. They have a great preceptorship program if you're ever interested in learning more about that. But I went through that several years ago. A lot of it I probably will never apply. It was a lot at that time was really geared more towards MDs and PAs, but I think they've expanded that more to the dental professionals. But I love the collaboration that they have created, and the buzz that they've created in our world of dental. This is actually from them as well. Again, we know that if we have bacteria going into the bloodstream, within 1 minute, it's reaching all of our organs. It's going to our heart, our lungs. It's going into our bloodstream. It's hit every place that it can. So we know that that bacteria is floating around, and 30 days after a dental procedure, a person can have a vascular event. So again, why are we so far behind here in this collaboration with medical? Medical should be paying for more than they do with knowing what we know. I get asked all the time, are dentists allowed to bill to medical? Yes, we are. As long as we are staying in our scope of practice. When we look at the definition of this, we evaluate, we diagnose, we treat. We do all of this to not only the oral cavity, but we are looking, when we're doing a head and neck evaluation, we're looking at all of this. So that allows us to bill to medical. We are no longer just tooth fixers. We're so far beyond that. One thing I was hoping with COVID that we would see a little bit different perspective about what our offices really are, because they truly are more like a surgery center than they are a practice, an office. All of our claims go out as office, but we really should be looked at more as like a surgery center. Whether we're cutting into tooth, tissue, or bone, we're doing same day surgery all day, every day. So medical specialty, what does that look like? Again, if we are truly a medical specialty within medicine, but a lot of people don't realize that. As long as we are specializing in the head and neck region, the oral cavity, we are considered a medical specialty. We are no different than, say, an ENT and how they specialize in the ears, nose, and throat, so we are truly a medical specialty. And part of this presentation is I want us to start wrapping our heads around and shifting our mindset about, gosh, we aren't just dental professionals. We're so much more than that. And we need to be recognized as such. And we also need to be reimbursed as such. I don't know how long our industry can withstand the increase in prices, the increase in demands for salaries, and benefits. So we have to start looking for other avenues for reimbursement so that patients can move forward with treatment and have better case acceptance and get more new patients as well. Because there's a lot of patients going to the ERs that don't have that don't have dental insurance, so they're not coming to you. Insurers don't really want you to know that we can bill to medical, and they love to play that card as well. And you will get EOBs back, and that EOB will say, yeah, we don't pay for dental procedures or dental something. As soon as I see that claim goes back for reconsideration with a nice little letter that highlights this section from the Protection and Affordable Care Act. And it just states that they can't discriminate our provider type. So if they were willing to pay an ENT for an evaluation, they should pay us. And they should pay us the same. So this letter works well every single time. I also want us to look at, we've got to start looking at dental insurance, what we call dental insurance, as a supplement. It's not an insurance policy. It's a supplemental policy. It's a coupon plan. It's a discount plan. Whatever resonates with you, we've got to start looking at it differently. It's definitely not an insurance plan. It comes with a lot of limitations, restrictions, and exclusions. For me, it's no different than I have my medical insurance. I also have a supplement through Colonial Life. and it's a supplemental plan that helps cover co-pays and things like that. They pay me $65 every year for a wellness exam with my physician. With having this knee surgery, obviously there's co-pays and things like that that go along with MRIs. And if I submit that to them, they will reimburse me for those extra services. So it helps decrease some of my out-of-pocket costs by having that extra plan. So that's all dental really is. Again, the maximum is 1,000, 1,500, maybe 2,000 if you're lucky, but it comes with a lot of limitations, exclusions, and restrictions, as well as frequency issues that really drive me bonkers. And it has that limited max. So why would we limit ourselves to just dental benefits? That's a question for you. What are your thoughts on that? Why did you come this evening to this presentation? I think there's a lot of people that are really concerned and upset with where dental benefits are these days, and the fact that nothing's changing since the 1960s. And you get this great fee schedule when you're in network, but half the stuff on there doesn't even have coverage. So it's kind of a joke. So what can we bill to medical? We can bill evaluations, we can bill radiology, so PANS, lateral cephs, CTs, tomographic studies are all billable to medical. Surgery, TMJ, sleep diagnosis and treatment, trauma. We have frenectomies, Botox for TMJ, biopsy, fluoride varnishes, advanced oral cancer screenings like with a Velscope or an oral ID. Systemic causes when there's a need displayed for medical necessity because a systemic condition is bombing out somebody's mouth. I also want you to look at, I love to talk about surgery because that's one of your biggest opportunities. Say a patient comes in for a surgery consult, or that they need a surgical procedure. Medical will pay for the evaluation and the diagnostics of that surgery. So your evaluation, it's truly not a consult. If you're going in their mouth, consults used really loosely in dentistry, but if you're going in their mouth and diagnosing and treatment planning, that's an evaluation. Consult is you have the data in front of you and you're reviewing it with them. That's more of a consult. So evaluations, the orthopanogram, that's what we use in slang language and terminology in dentistry called a panorex, CT. And then when the surgery is happening, they will, if they pay for implants, they're going to pay for a surgical stent, grafting if needed, an interim prosthesis, and a final prosthesis. The implants, surgical stent, interim, and final prosthesis all go hand in hand. So it starts with the implant, and if they pay for the implant, they'll pay for those other 4 things. So you're going to see some great examples of that during my slideshow. The biggest thing that separates us from medical and dental.
One second. Look at the question. What was that?
How do you do a predetermination or?
How do you do a predetermination or anything along those lines?
It totally varies depending on the insurance carrier.
Is it
What about Medicare?
with Medicare?
Medicare does not allow you to do, so predetermination is also used a lot in dentistry. Predeterminations are typically not allowed or normal in medical. If you need a prior authorization, that, again, that can be done. However, that carrier does that, whether it's online or via phone call or whatnot.
Would that be directly, sorry for interrupting. Would that be something directly to, say it's Blue Cross and Blue Shield or Aetna or whatever the medical carrier is? You would do that directly on their website?
Sometimes you can, sometimes you can't.
Okay.
Yes, they're all different. There's no one place to go for all of that. So it's just like with dental, you have multiple websites that you go to access information.
Okay, hold on.
So
you have insurance is covering before you do anything.
So you don't know what is covered before you're doing anything, was the comment?
That can be the case. You will know if the patient has coverage for via their policy and their eligibility and benefit checks. I think that's the trickiest thing about this, because most providers are out of network with medical, and they choose that for multiple reasons. One, because they've been tainted by dental benefit plans. If you are in network with dental and you can go in network with medical, you shouldn't be afraid of their fee schedule, because it's going to blow you away what I show you tonight. In my findings, it's, you know, medical will pay 2 to 12 times higher than anything in dental. So that you shouldn't be afraid of. But that being said, there are many carriers that don't allow a dentist in network. Therefore, you don't have a fee schedule to go off of. Now, that can be tricky, but the more claims that you get out, and even through retro billing, you start to gather a really good database of about what the maximums are. What I can tell you is I've never seen a dental practice where this doesn't happen, where we start submitting claims with the fees that you currently have, and they are, you know, they're processed 100% of the allowed amount. So there is that. To me, you know, whatever your fee is your fee. And the more knowledge you can gain through, you know, utilizing a coach like myself that knows what's happening in the industry, and getting to understand what carriers you have that are big players in your area, and getting EOBs back and seeing what's coming back, then you can start to make more decisions about fees. But there is really, I just got a pre-D back today, and they do not give you their fees if you are out of network. You will not get that until the claim process is through. So your fee is your fee is your fee, and it's our job to be the solution to that.
Okay, thank you.
Okay. So medical necessity is really the key here. A dental claim, we can do dental claims all day long. A dental claim does not have to have a diagnosis code on it. And that's one of the biggest gaps. We were never taught diagnosis codes in school, and most people don't know them. So that's one of the biggest things, is establishing medical necessity. And medical necessity is just simply supplies or services needed to prevent, diagnose, treat an illness, an injury, a condition, symptoms. That's all it is. So the diagnosis is really pretty simple to achieve. So we're really looking at medical necessity is established using diagnosis codes. Why did we treat somebody? That's really our golden ticket, is medical necessity, and understanding that. Because that's different, but it's not that difficult. In fact, if we look at this picture, other than the overlap, every time I present this, I'm like, it is a good picture, but it's the overlap. It really could be better. It could be a better image. But I want you to look at that. And I mean, what do you see on that? I see a lot of teeth, and medicine doesn't like that. They want to see more of the other structures, but we do have some things that involve teeth. So this is what it would look like. K0 2.63 is dental caries on a smooth surface penetrating into the pulp. So it's not tricky to understand and find diagnosis codes, and I'm going to show you how to do that. But on a medical claim form, we can't even validate our claim without a diagnosis code. Back in 2012, ADA came out with their little spot where they have diagnosis codes, and there's room for 4. Nobody knows what to do with them because, again, we weren't taught diagnosis codes. But I always hear from admin team members is, dental. They always are asking for more and more documentation. Well, it's probably because they don't know why you did what you did. They want to know, and the diagnosis codes establish that. That being said, I don't know if you put a diagnosis code there, if it would help. I don't know. I don't know if they would even know what to do with it. I think they might not. So, you know, again, that's been there since 2012 and nobody knows what to do with it. If we look at a medical claim form, it's called a CMS 1500 form, and there's 12 spots for diagnosis codes. So a little bit different. It's got a lot of the same information, just a little different format, called something different. So medical necessity, a claim will not be paid until medical necessity is established. Otherwise, they will deny it. I have seen that where people have said, yeah, we tried medical billing, it didn't work. And I've asked them to show me what they did, and they didn't have any diagnosis codes on the claim. So the claim never came back. It never got processed. It probably got dumped in the trash, probably rejected. So that's the key, is getting to know and understand that. Here's what it looks like. So this was a new CT owner, and she had taken a CT on January 4th. She wasn't real comfortable with reading them yet, so she sent it out for an interpretation. And you can see the dates there. So 496 this is on the 4th of the year. So January 4th. So when we talk about deductibles, because I know that'll come up, but I will get to that. So $496 for the CT and $150 for the interpretation that she paid for. That interpretation came back with 4 diagnosis codes. So what we did is we used those 4 diagnosis codes as to why we took the CT. And voila, we were paid 100% of what we billed. So I always start with the abnormal radiographic finding, and then what did you find on it? One thing to consider here when we look at diagnosis is systemic diseases, and how that can affect oral health. They can be a little trickier to get prior authorizations on. However, they are a good opportunity. That's not just surgery. This is Brad. Brad at this point was, I want to say he was 21, 22, 23, somewhere in there. And Brad wasn't supposed to live past the age of 9. And you can see that he had crowns done in the anteriors. They were actually done at Mayo Clinic. His parents paid out of pocket for them. Brad has a lot of medical conditions, things I couldn't even pronounce. And they have thousands of dollars a month going out on medical expenses. So Brad was taken off of a feeding tube at this age, and he had nothing to function with. So we submitted all of his clinicals for prior authorization, and were able to get his posterior teeth, gingivectomies, crown buildups, and the final prosthesis or crowns on all of his posterior teeth on the maxillary and the mandible. So that was a huge win. And again, patient centric. I mean, I will never forget his mom, calling me and, thanking me for getting all of that covered for him, because it was several $1,000s that they would have had to pay out of pocket otherwise. And that's why I do what I do, just purely for that. Every claim that we get processed and paid for a patient is a huge win for the patient. Just so you know, there are over 72,000 diagnosis codes. Brad's had quite a laundry list of diagnosis codes, but there are over 72,000. So there are diagnosis codes for just about everything. And I want you, I use this website. It's called icd10data.com. You all probably have your phones with you. I'd like you to get on your phone and get to icd10data.com. And I want you to type into the search engine, sucked into jet engine. And I want you to, somebody yell out, what codes are you seeing? Unfortunately, this has happened more than one time that we have to have code sets around it. I mean, that's crazy. Anybody got anything?
Yeah.
You're gonna see a bunch.
Sequela, initial encounter, subsequent encounter.
So right here are four. And, you know, this is how we get to 73, if every code has got a bunch that tag along with it. What I want you to notice what's that?
Person injured while boarding or while riding from ambulance or fire engine.
Oh, I know. It's actually pretty hilarious to start typing stuff in there and see what you get. But I want a couple things I want you to notice about this when you use ICD-10data.com is this red arrow means that that code would not validate on a claim form. It wouldn't go through. It's looking for more information, more definition. And if you're on that website right now and you click on that, you would then be able to see all the others as well. So sequela, well, the initial encounter, obviously. Then you have the patient comes in as typically emergency. Initial encounter, they come back for treatment. That would be the subsequent encounter. And then sequela is, say, a year from now, the patient ends up needing a root canal. That would be a sequela type event. So just a little fun exercise about how to find diagnosis codes. And there, you always want to look for the green. Here is severe atrophy of the maxilla. And if you type that in, you're going to get K08.26. And if we look at the same patient, her mandible is in the same condition. And there we go, severe atrophy of the mandible. I always, when I see this person and I know who this person is, I just think of, you know, them bouncing their granddaughter, grandson on their lap, and, you know, accidentally the child pops back and hits him in the jaw. You're looking at a pathological fracture, potentially, or obviously some nerve problems because of the position and not having a lot there to go around the nerve. So that's how easy it is to look up diagnosis codes. So there's diagnosis codes and then there's procedure codes that are different than dental. I want you to know there's this term called cross-coding out there. It's really linear thinking. There really is no such thing as cross-coding from dental to medical. There are with some procedure codes, but not all. And sometimes, you know, like grafting, there are multiple codes in dental for grafting. In medical, there's about 2 that we use. One for maxillary, one for mandible, that's it. Now, for biopsy, same thing. There's some, you know, you're removing a certain size lesion. And when you try to cross code it to medical, and give you a laundry list of lesion codes that it could be. So it's really linear thinking to think that there's a true cross code 1-to-1 ratio, because there's not. So deductible, there's no good place for deductible in this presentation, but I'm sure you guys are thinking it, and you guys are smart. You already asked about the pre-D. So the deductible is truly just a term. And this term is not all-inclusive to every procedure code. So it may not apply to every procedure code. I know personally, I have a $15 copay when I go to see my physician, and for specialty it's $50. And basically it doesn't apply to my deductible at all. I just pay a copay. So that's that's just an easy example to understand, because a lot of people have plans like that. And I'm going to show you, here's an example of sleep diagnosis, and then the actual home sleep study test. So the diagnosis, and this is all submitted on the same date of service. They did a tomographic study, an orthopanogram, an evaluation, pharyngometry, lateral ceph, rhinometry. Everything was billed out. Nothing went to copay. Nothing went to deductible. Everything, there was a small portion that went to co-insurance for all the diagnostics for this. and the rest was paid. So nothing applied to deductible here. Now we build out the home sleep study, the HST, on this with the same data service. And now you have nothing for copay, coinsurance, but it applied to deductible. So that's a great example of codes that do or don't apply to deductible, all in the same data service. Here is a surgery that was done on January 5th, I believe. It was the first week of January. This patient had grafting, implants, alveoloplasty, interim prosthesis. We billed out $33,300 and 100% of it was paid. Nothing went to deductible. Now, what I found out is that this patient has insurance through John Deere. And I thought, cool, that's really awesome. They have amazing surgery benefits. Like if you have a patient that comes in from John Deere, we need to look at billing to medical. But what I did find out is that John Deere had like 4 different plans that they offer to their employees. So, you know, I don't, so now it's going to depend on what's offered to the employees, but still, obviously this is it was a huge opportunity for the patient, because we did about the same amount of treatment on the mandibular, and between the maxillary and mandibular full reconstruction, it was about $75,000, and we had approximately $250 that went towards deductible. So that was it. And that was, again, the first surgery was the first week of January.
Okay, we have a question.
What kind of medical necessity can you throw in to get implants, grafting, and everything covered?
It's all gonna come down to atrophy of the bone, pneumatization of the sinus, disuse atrophy. That's what they're looking for.
Thank you.
Is it the same in a single edentulous site versus a full arch?
Yep, it is. So really, it all starts here, though. It all starts with evaluations. And that could start in your hygiene chair, could start in a patient coming in and just having an evaluation for surgery. But it starts with evaluations, which are billable to medical. It's a huge opportunity for medical and to increase your profits. On average, I see evaluations getting covered about $35 to $50. And I have a provider out in your area that's billing out $210, and they're allowing 100% of that. So that's a huge difference. That adds up quickly. It may not sound like a ton of money, but when you add that up over time, it's a huge ton of money. So it starts with evaluations. And what we have to do is we have to get past looking at the teeth. It's not about the teeth. Medical does not care about the teeth. So this is Jack. Jack's got a lot of stuff going on here. And it's debate, everybody would probably have a different treatment plan for Jack, but we have to try to look past the teeth and start looking at the structures around. Because really, unless there's a systemic condition that's destroying the mouth, dental or medical is not going to pay for teeth, unless they're impacted. So forget about those teeth that are flapping in the breeze anyway. So let's look at what medical evaluations are all about. In dentistry, we have about 4 that we use. We have an 0120, an 0150, 015, or 0180, and typically an 0140. Those are our highest amount of evals in most practices, the most done per year. And in dentistry, it's not in dentistry, in medicine, it's very different. That 0120 comes with, think of it this way. An 0120 has a benefit attached to it, whether it's $35 or whatever it is in your area. But that doesn't change based on anything. that's the benefit. That's it. If you're in network, it's this amount of money. It doesn't matter how much time we spent with the patient or how complex the treatment was. In medicine, it's very, very different. You get paid to think. How long does it take you to come up with a treatment plan? How is the medical decision making, how complex is it? Is it straightforward, low, moderate, or high? How much time did we spend with the patient? That includes FaceTime and non-FaceTime. So it's a very different thought process. And I try to use that 0120. Think about a 10-year-old versus an 80-year-old. That, if you're using an 0120, it's probably not the right code anyway, but if you just look at that, you're going to get paid the same, no matter how complex or how much time you spend with the 10-year-old versus the 80-year-old. It doesn't even make any sense. It's true that right there shows it's truly a benefit plan only. So medicine does it different, and it makes a whole lot more sense. When we look at the codes for evaluations, you have new patients on the left, established patients on the right. Medical decision-making right in the middle stays constant. The time for new versus established patients changes based on that, and you're always going to go with what's higher. So say the medical decision-making was low, but you spent 35 minutes with the patient and it was established patient. You would pick the 99214 over the 99213 because you're going to go with the higher of the two values. So now all of a sudden, instead of 4 codes that you're working from 8. And again, it's based on your time and your medical decision-making and the complexity of that. I want to show you this, and this was a very vulnerable time in mine and my husband's life. This was back on the 21st of August, so just a little over 2 years ago. My husband entered the ER with COVID and fought for his life for 11 days. He saw an ER physician. They did a level 5 ER evaluation, and that physician charged out $1,619. Okay. Our insurance paid $1,133.30. It's pretty darn good payment. And we're trying to capture $35. Whole different ballgame for medicine. Now, that being said, he was then brought up to the hospital floor to be admitted. And each of the specialties billed out on the same day a new patient consult, what they called consult, or initial, that should be really an exam. I don't know if it was truly a consult. Either way, they billed out $495 each on the same day. So the ER doctor, the pulmonologist, the cardiologist, the infectious disease doctor, our primary care doctor, and it seems like there should be someone else in there. But you get the picture. In dentistry, how many exams do we get per year? 1, 2? I'm hearing some insurance carriers have dropped it to 1, which is insane. So this is how medicine rolls. There's no limit to your evaluations. This all happened on one day. And look at how much was billed out. $495 was billed. Our insurance paid $430.66. So hopefully you're starting to think a little bit more about why are we dealing with these skanky dental benefits? All right. What things that we have to look into, things that we have to start keying into and documenting is, wasn't it an emergency? Was the patient in pain? Was there infection? I think the things on here we are so used to seeing, we do not document it. It is like our daily life. We have somebody come in for an emergency or has pain, an infection. Those top 3. I rarely see in documentation in the practice. I rarely see that even documented because it's just the norm. bone atrophy, and what kind of bone atrophy do they have? Pneumatization of the sinus. Was there sinus communication when you extracted a tooth? Was there loss of function? How about did the patient have cancer or trauma? And what kind of cancer? How were they treated? Surgical? Was it surgical, radiation, chemo, all three, medication, trauma? What kind of trauma? And trauma is blunt force injury to the mouth. And those things, when we're talking about emergency and trauma, it's considered an emergency when it is 72 hours of onset of trauma or pain. So, and then is there a sleeping or breathing issue? So those are some big things that we need to start really keying into, documenting and identifying. Nowhere there do you see anything about teeth. The very first thing that I do coming into a practice is incorporate a new medical history form. The medical history forms coming out of the dental software is really not sufficient for medical. Medical wants to see a review of systems, and you'll see that kind of laid out on here, where it's you've got allergies, gastro, psych, cardio, it's all broken down into different systems, and that's what they want you to review. And if we're really going to be starting to look and act like oral physicians and bill to medical, this is a great way to introduce that to our patients, because there's so many things that we do. And I don't know how many times that happened to me in hygiene, where you'd be cleaning, doing a hygiene appointment on a patient and be like, oh yeah, I had a heart attack 2 weeks ago. You're like, what? Or I had a knee replacement or whatever it is. They don't have an idea that there is a link. And so this is a great way to start closing that gap with our patients and their concept of it. We do blood pressures. This is part of what we do, and it's part of our process to diagnosing and coming up with treatment plans. Obviously, we have to be careful with blood pressure when we're treating patients. This is a form that we utilize when we do oral cancer screenings, and when we do just a head and neck evaluation, because I often see on documentation OCS, oral cancer screening. And when we're doing that, we're not just looking in the mouth, we're doing the whole head and neck, TMJ, we're doing all of this. We're touching for lumps and bumps, intra, extra. And then sometimes we're using advanced technology too, but we don't document it. We document it as OCS. We got to document it as what it is. So we need to usually beef up our documentation. When we look at oral cancer screening and maxillofacial cancer screening, this is a huge opportunity. With oral cancer on the rise, when we are dictated by dental insurance that we can only take a pan every 3 to 5 years, that's what we just do then. And we'd have to choose between one or the other. Well, what happens if we're not ever taking a pan? We could be missing maxillofacial cancer. And that's going to be on us. So you could actually take a pan every year as a screening tool. So we can actually enhance the type of treatment that we're providing for our patients and stop letting dental benefits dictate when we do what we do. We have pretty much allowed them to dictate how much we charge, when we charge, and how often we charge. If we look at diabetes, huge complexity issue when we're doing surgical stuff. So that's part of our complexity when we're looking at our evaluations and treatment planning and understanding, the opportunity for infection. So we have to, take protocols differently with diabetics. Same thing with sleep. We can make a huge difference with sleep by just simply screening. That can be part of our overall evaluation, is screening for sleep apnea. And there are diagnosis codes for that screening. And that screening could look as simple as an Epworth score, stop bang. Easy peasy things to do in a practice. We just run out of time, and we don't have time with what we are being reimbursed for our time. So it's hard to schedule enough time to get all these things done that are in our toolbox. Carrie's risk assessment out of hygiene. You know, if you're doing high fluoride varnishes, are we doing a Carrie's risk assessment? Here are the codes for Carrie's risk that would pair with a fluoride varnish. Now we have silver diming coming out, and there's a code for that as well. That came out, I think, in July. I don't have anybody that's using it yet, but it is out there. But Carrie Free, they've really been the biggest advocate for caries prevention. They have a great form as far as how do we know if they're low, moderate, or high. They've got all the information there, and they've got all the tools and things to help prevent, because it is the number one, caries is the number one disease in the United States, number one, and it is an infectious lesion. It's a disease, but I think we're so used to seeing it, and medical doesn't get that. They don't get that it's an infectious disease. So hopefully that paradigm will continue to shift. So let's look at imaging as part of our evaluation. What does that look like? Diagnosis, radiology is used to diagnose. Again, more thinking. The more things that we do in our evaluation, the more time we spend, the more things that we have to evaluate, that increase what we should be billing for our time. So obviously there's a lesion here, what we would call an abscess. Truly, it's a cystic lesion in the jawbone. What would your MD do in a situation where they found an abnormal radiographic finding? This is only a 2D image. Ideally, we should be going to a 3D. We should be going, anytime we see an abnormal radiographic finding, that is our number one diagnosis code on our claim form as to why we're going to a CT. And I love this because look at where that infection's going. Right down into that blood supply. And on the right-hand side, you're looking right into the sinus. So a 2D just can't give us what a 3D can. So when we look at 2D, that 2D says, hey, we can go to a 3D now. And you know, when we talk to patients, I think a lot of practices have you know, they're worried about the ROI of buying a CT, but the problem with that is that we give it away because we know that dental doesn't cover the CT. So we feel bad asking our patients to pay for it. And pretty soon, you know, our ROI is nothing. But this is a valuable tool. And I always say, you know, tell your patients, we see something abnormal on this x-ray. We really need to see if it's embroaching the sinus cavity, their mandibular nerve, because when we take this tooth out or we do treatment there, you know, you could end up with, you could have you know, we could pinch the nerve and cause nerve damage. I mean, when you start to talk like that with your patients, they're going to be okay paying for it. There's nobody that's going to touch my knee that I'm having surgery on without an MRI. Absolutely not. They wouldn't even think of it. But we do it in dentistry all day long. Here's what it looks like when you get paid on a CT. This just happened to be one that was paid at $375. Say you do 25 of these a month. You take that times 12 months and you've paid for your CT. What if you only charge, maybe 375 sounds too much for you. I'm not here to tell you what you should charge. I'm showing you some examples of what's being allowed in medical. You can see on this EOB, this ERA, that 375 was charged and 375 was allowed. But what if you felt uncomfortable asking for that? Look at 175. That is not unreasonable. Now, the other thing about CT is that you can bill out the day that you diagnose the problem, along with an exam. You can bill out a CT the day of surgery, to verify the integrity of your surgical site or placement of your implant, along with the sinus cavity and the mandibular nerve. And 91 days post-operatively, I would have them on my books to reassess and bill out another exam and CT. So now 3x that. That's just CT in your practice. All right. Here's what it looks like when we put it all together with eval, orthopanogram, CT, and tomographic study. So you can actually bill from your CT if it extracts a pan and you extract that pan. You can bill out an orthopanogram or a pan. You can bill out the CT and you can bill out the tomographic study. They are all separate, identifiable, billable services, along with the evaluation to read them. Does that look a little different than what we're doing now in dentistry?
So the tomographic study, how is that different from the regular CT?
You're studying the slices of the CT. The CT is just the capture.
And
We good?
so any questions? Other than just general confusion?
Well, I was hoping you'd say like, there's a few jaws on the table. Like, oh my gosh, this is crazy.
They're more than a few.
And that's the hard part for me. I can't see you all, so I don't know what your reactions are. You're like,
This
she's
is a
crazy.
totally new language.
She's a crazy lady. I don't know what she's doing. Yeah, no.
It's totally new language dealing with medical billing. Because you're right, when we say that, you know, you have your 2 exams a year, and if a patient comes in on an emergency, if it's an emergency exam, oh, you're not getting paid for it. I said, and it's minimal that we're asking, and they don't pay for it. They don't pay for the general post-op office visit, but in medical terminology, they would pay for it fully.
We give a ton, thousands of dollars away
Yeah,
a year. In fact, I just wrote an article and submitted it for Dental Economics for the December issue about that. You know, the thousands of dollars that we give away.
so,
Because again, we've been brainwashed by dental benefits. We
Well, here's
really
my-
have. Myself included. I
yeah.
was brainwashed by it too.
So you have a patient that has medical insurance and dental insurance, and they're sitting in your chair. What do you bill out primary? Is there such a thing as primary and secondary? Or is it just sent out to dental and sent out to medical, or is it only sent out to medical?
Well, it depends on the situation and if you're in network or out of network with dental. So you can bill, just know that you can bill to both.
But you
To
bill
recoup.
both as primaries?
Well,
Does dental have to know medical exists?
well, they're going to want to know if medical exists, but if you bill to dental first because you're in network with dental and you have to bill everything to dental, whether they pay for it or not, and you bill to medical second, dental's not going to know. The thing that you have to be cognizant of you can't double dip and keep. And when I say double dip, going to medical and dental is not double dipping. Double dipping and what's fraudulent is keeping more than you charged, more than you billed. So if the service was $100 and dental paid $50 and medical paid $100, you now have a $50 overage and you can't keep that. That would be fraudulent to keep. You can only keep up to the 100.
Who'd you send it to, medical or dental?
If you submit it to both. And the overage would go back to if the patient gave you any money, that created part of the overage. In that scenario that I just said, it was just dental and medical and patient wasn't involved. But medical created the overage and you would give medical the $50 back.
But how do you define that medical created it, not dental?
Because
When-
medical paid you second and created it. You didn't
Oh,
have it with dental.
they paid you second.
Mhm.
I got
You can't have two claims out at the same time for the same services.
Okay. But it makes sense to me, if you're not in network with the insurance, it would make sense that you'd always want to fill out medical first. Because
A lot of times, the only reason I don't initially with the client is, I usually just have them do what they're already doing because everything's so new. And I don't want if we have a problem with our claims processing through to an insurance carrier, I don't want your AR to go up.
Mhm.
So that's the only reason why we start with keeping it going to dental first. So it's just doing what you're already doing. A couple months down the road, as things are going smooth, or smoother, and we don't see any hiccups with that, then we can make choices about, guess what, we're going to go to medical first. And if you're out of network and you know that dental's not going to pay, and you're out of network with dental, if you know that they're not going to pay for the CT and the, like, say, the grafting, go directly to medical and forget about even submitting it to dental.
even
You
just
know, it doesn't make any sense. What's that?
restorations, because the disease / decay is existent and they have high blood pressure and diabetes. So could that go directly to medical if you're out of network dentally first?
Well, so in a situation like that, I can tell you systemic conditions are harder to get through medical. And it's mainly because we have to use an unspecified code, which we have to describe. And typically that requires a prior authorization to go to medical review.
I thought a lot
So
of
that's not where I would start with medical billing. I would start with all the other stuff I'm showing you right now.
Okay. Now, you submit to dental, then you submit to medical. When you have two dental insurances, a copy of the first payment claim goes to the second company. Does the same thing happen with medical?
No, medical doesn't care about dental. Dental cares about medical paid because they're not going to pay you a penny over usually.
Mhm.
They're going to want to see the EOB. On a medical claim form, there's a spot for a secondary insurance, but it's a spot for medical secondary,
Okay,
not dental. Yeah.
okay, thank you.
Mm-hmm. So let's talk about communication and documentation. This is a big deal because I often see the documentation typically does not match well with what was done. And we could bill all day long to medical, but if we do not have the supporting documents to support the claim and make it medically necessary to do, they're not going to pay you. So I'm going to go through this kind of quickly. I love SOAP notes. That's what medicine uses. And each of these, it helps for so many reasons. If you have multiple providers, everybody's putting the information in the same spot. And it just makes sense how it flows. So this is what medical is going to expect. S is subjective. Listening to the patient. What are they telling you? That's all. What are they telling you in their words? Why they are there that day?
It's just, there's all this pressure,
Hopefully you can hear this.
and sometimes it feels
Not really.
Can you turn it up on your end?
I don't know if it's gonna.
Nothing.
No, you don't hear.
Hold it. Hold on, I just did something. Uh-oh. Oh,
No, you were on that before.
is for you to just listen.
Exit. Just push input on the remote.
Input? Where's input?
Right there. Over that, right there.
This?
You're on.
Looks like you're on it, you're on
Oh. There's no sound.
Okay. That's all right. We'll go, oh, see if it'll let me go through it. Okay. It's kind of a fun video of just, really listening to what somebody's saying and how does that communicate? Where does that communication start? It should start with your admin team that's taking the phone call. And I often see the information of what the patient said to them, not get back to the clinical team. So it's important to listen so we can document that. And again, documenting if it's an emergency, documenting if they're in pain. And then going to, the medical history is part of this whole evaluation. Again, looking at cancer, any oral systemic conditions, xerostomia because of certain conditions, just asking better questions. And then we have O. O is the objective, all the stuff we do, all those things in our toolbox, vital signs, the medical history, the oral cancer screening, bleeding upon probing, radiographs, any blood tests, salivary tests, all that stuff is part of our O. It establishes this medical diagnosis codes. What did all of this information get us to a decision of what's wrong with the patient? So we have encounter forms or super bills that have all these codes on them. And we customize those for clients, but it basically, that's the O, your assessment. What's your diagnosis based on all the stuff that you evaluated? So anything that's on that super bill should be in your O of your note. And then what's the plan? What's our step-by-step plan for that patient? We really need to start looking and shifting our mindset about our terminology, our documentation. Implants are not, we don't want to use the term implant with a medical carrier. We want to call them a bone fixture or a surgical bone fixture. Panorex is not a pan, it's an orthopanogram. Bone loss, it's bone atrophy. And what kind? Is it minimal, moderate, or severe? Is there an abscess? It's a cystic lesion. It's osteomyelitis in the jawbone. Crown, bridge, it's a fixed prosthesis. You all doctors, you didn't go to crown school. You didn't go to crown class. You went to prosthesis, the prosthesis class. A flipper, it's not a flipper. It's called an interim, final removable prosthesis. Tooth numbers are, they use the same numbers, but in medicine, instead of the hashtag 2, they use JP for jaw position and then the tooth number. Root canal, endodontic therapy, filling, it's a dental restoration. CBCT, it's a CT scan. It's not an iCAD, it's not a this, it's a that, it's a CT scan. You'll never hear a medical provider call it a CBCT. It's not called that. I don't know where that even came from. So one thing to know about all this is a marathon, it's not a sprint. It takes time. It takes a shift in our way of thinking and how we do things. It takes time to integrate this into a practice. So here is that super bill. It is basically just a communication tool between clinical team and admin team. That's it. Never goes to the insurance carrier. It is simply just to communicate. On the left is your procedure codes. In the box is your diagnosis codes, and it's just there to communicate what you did and what you want billed out. So recommended documentation, documenting the time to justify the level of the evaluation along with your medical decision-making, medical conditions that affect care, and knowing the status of that patient. Counseling, oral hygiene instruction, that counseling or referrals are all part of our time with the patient. And that all takes time, energy, and it increases the complexity of the encounter. Radiographic interpretation. If you have a 2D image, say you have a PA, you see something abnormal, you go to a pan, you take a pan, you're having to read that now. Now, oh, we want a CT. Okay, so now all of a sudden you have three things that you're interpreting, you know? Another example is wisdom teeth. There's 4 surgical sites. Now that might seem very straightforward to you, but it's 4 different surgical sites that could potentially have a problem during surgical encounter. So while it's straightforward, it's really not. If it was one site, that'd be probably pretty straightforward, but remember that there's 4 different sites of surgery. And then our diagnosis. So WNL, I mentioned this earlier. What does that stand for? Typically, it stands for we never looked. I see that often when people ask me, you know, when clients ask me for documentation templates. I have to be really careful because stuff doesn't get changed on it. And that's not good. They really dislike templates. So I want to show you something, and this is stellar documentation. I love the way the doctor did this. Intraoral photo. What is this? Patient came in, basically said they couldn't get their upper partial in anymore. I think it looks like a corn nut, but it's very odd. Like, what the heck is that? So here's the x-ray. Give you a little bit more clue what happened. The tooth evulsed itself because of whatever formation is going on up there. Obviously that all got biopsied and sent for pathology. But the tooth evulsed itself and just got stuck in the cheek. Now, the provider went a step further and started measuring all that cystic lesion. So every time she had an abscessed tooth, she would measure the size of it and put it in her notes. I loved that. So just really great documentation. Operative notes are super important. Again, if it doesn't meet medical necessity, they're not going to pay. So those are things that we work on with practices is getting stellar documentation in. Sometimes the notes are already pretty good, but we just enhance them. Sometimes we have to kind of start over from scratch. But you know, making it, again, you can medical bill all day you want, all day if you want, but if you don't have documentation to support the need for the services and they ask for it, they're not going to pay. So here's a scenario that comes into your practice quite frequently. All right. Pretty simple. But what if we have to write a letter of medical necessity? This is rare, by the way, but it's an easy example. If we sent this to medical, do you think that they would pay for anything?
No.
I see a lot of dental verbiage in there. We did a dental examination. We did a Panorex. They weren't even going to know what that is. And the patient had a cavity, and we did a DO resin, a DO resin filling. They wouldn't even know what to say. What about if we presented it like this? They don't care about the tooth, for starters. What we want to try to get paid is the exam and the orthopanogram. Does this sound more medical and pay us? So that's important. In a letter of medical necessity, you got to have history, diagnosis, what was rendered, and contact us if you have any issues with our claim. So pretty simple. Here's a scenario, kind of taking it to the end here. Scenario of an abscessed tooth that you guys see all the time. Patient comes in, they've got swelling, obviously endodontic lesion that's failing. Would you send it to medical or dental? So let's break it down into a SOAP note. My face is swollen and it hurts. That's our S. Here's our O. I want you to notice in these notes, very minimal discussion about the tooth. We are concerned about the infection in the jaw at this point. Forget about the tooth. It's history, non-restorable. Here's our A. Jaw pain secondary to nerve compression, cyst of the mandible, cellulitis, inflammation of the jaw, lymphadenopathy. Cyst was removed that day. And you can kind of see the notes there. Okay, that's a SOAP note. My SOAP notes look a little bit more than that, but depends on the encounter. Again, this is just a simplified version of it. We would then put onto an encounter form or a super bill, jaw pain, inflammation of the jaw, lymphadenopathy, cystic lesion, cellulitis, an eval, and cyst removal was done that day. We could have done so much more. We could have done a bone graft if needed, with CT. We could have done more than just a cyst removal. But here's how the flow goes in an office. You have this encounter form, this super bill. It works as a communication for things that you did that day, as well as prior authorizations that need to be done. So this is clinical. SOAP notes, operative notes are clinical. From that, our admin team can do their work with maybe a letter of medical necessity and a claim. I want us to look at this scenario again. Is this an abscessed tooth or is this osteomyelitis of the jaw? Medical is going to be looking for osteomyelitis, infection, cystic lesion of the jaw. Not an abscessed tooth. They don't care about teeth. The other thing that we should be concerned about is 50% of heart attacks and strokes are due to an oral infection. This came from Dr. Bradley Bale and Amy Doneen, who I talked about earlier. This is what we should be concerned about, because this is happening every day. And a lot of patients are going to the ER with pain. They're not coming to you because they don't have dental insurance. But what if they had medical and they could come see you? Because what's going to happen is they're going to get to the ER. ER is probably not going to treat them. They're going to refer them to a dentist that they didn't go to in the first place. Dentist, they still don't go to the dentist. And the patient ends up back in the ER with potentially sepsis, potentially dying. And it is something that is happening. People do die of these infections. I have a friend, a very good friend, who's a transplant nurse. And she's like, you have no idea how often that happens. Something so preventable. So this is a great stat to use with your patients as well. All right. At the end of the day, you do have a practice to run. So I'm going to show you the money. I think I've already showed you quite a bit of money, but I'm going to show you more. And, you know, I hope that you guys aren't thinking, you know, I hope I kind of say things at times, and it's certainly not to make any of you feel bad that you're not billing to medical. There are very few practices that are doing this, even specialty practices. And again, for me, it just doesn't make any sense. I don't understand why, but you know, it's something that you have to decide if it's something that you want to venture into. Because you know, my goal is for you to see what opportunities you have. So I'm going to show you the money and what's possible. This was for a mandibular graft, cyst removal, CT, and tomographic study, all done on the same day. You can see the charges were quite significant. This practice happens to be in network with their local Blue Cross Blue Shield. And actually in their state, if you are in network on the dental side, you're automatically in network on the medical side, which is fantastic. But look at the reimbursement on that. That's like a wowza reimbursement.
Mhm.
All right. Same type of thing. I love to do retro billing. So you do have the opportunity to go back for most carriers up to 365 days to retro bill for anything that you build out. It's a great way for you to learn. It's a great way for the admin team member that's going to be doing the billing to learn. And for us to gather information about carriers in your area and how much they're paying so that you can make decisions about your fees and where they're at. And do you want to increase them? Do you not want to increase them? There's nothing to lose on a retro bill because you've already been paid what you've been paid by the patient or the dental insurance, especially if, in or out of network. So you have really nothing to lose. You only have knowledge to gain. Here's the $9,500 per quadrant. This was a pre-authorized ahead of time. That the insurance company came to us and said, we want to negotiate the fees before you do the surgery. This has never happened again. And I was like, can we do this every time with this doctor's surgeries? They said no. But clearly I started looking up and I'm like, okay, we really looked at a total case fee for this patient, and implants weren't covered. So we looked at a total case fee. And then we started dividing things up, and I did some research and I thought, okay, I'm going to put out there $9,500. I think the fairhealth.org was saying 11,000. I'll put out 9,500. And I thought that was really steep. I know for surgical stents, they pay more than 800. And I literally submitted that and I waited. And within 15 minutes, I had an approval. I couldn't believe it. It was insane. But great for the patient, great for the provider. Here's another one with bone graft and IV sedation. So they do often pay for IV sedation for these surgeries. Again, that's going to be totally based on the patient's plan, whether or not they pay. We can skip through that one. Implants. If they pay for implants, they'll also pay for the removal of an infected implant, by the way. And then, like I had mentioned earlier, they'll pay for the final prosthesis as well, or that crown to go on top of it. So we have to look beyond the teeth. And here's Jack again. Here's some diagnosis codes that could be potential for Jack. Because diagnosis codes are truly the key to the success of this. And there could be a whole lot more. But those bottom ones too, the F, G, and H, those are all, screening. The nicotine, the personal dependence on nicotine, there's codes for, hypertension, diabetes, things like that, that again, create the medical necessity as well as the complexity of the situation, increasing your payment. So other things to consider, building your knowledge base with retro billing, going back. You have nothing to lose. You're going to focus on PPO plans because you are going to be out of network. So you're going to focus on PPOs, no HMOs, no EPOs. If you're not contracted as a par or non-par provider for Medicare and you've opted out completely of Medicare, you cannot submit a claim to them. So that's how Medicare works. Again, our financial arrangements shouldn't change. Your fees are your fees, and that is what you present to the patient.
Basically, excuse me. So you're basically taking your fee, and instead of having one number, you're breaking your one number into 5 different categories.
You could do it as a total case fee.
That's
a harder thing to do right off the bat as you're learning this, but as you get more savvy with it, it becomes, a great topic to talk about.
Now, if you're, okay, so I'm DME certified for, just durable medical equipment. That has nothing to do with, Medicare then, correct?
Well, DME certified,
I'm DME only for durable medical, only for sleep apnea.
okay. Have you credentialed with Medicare?
For DME, yes,
Okay, okay. Okay, so then you can bill sleep appliances to Medicare.
correct.
Yeah, Medicare, you have to, it's a whole separate credentialing process than
Yeah.
for regular claims.
100-page credentialing form. What's the other question?
The bad thing about that is Medicare pays so low
Right.
on the sleep appliance. I mean, you're hardly making any money, and sleep cases take a lot of time. And not that it's all about the money, but I've seen low reimbursements of like 350, or not 350, 950. And your sleep appliance is, your lab fees are 500.
In our area of Bergen County, the Medicare with a someone having a rider usually covers about anywhere from 18 to 2 grand for our area.
Not Medicare though. You mean just regular commercial carriers?
That's Medicare, and then the commercial carrier picking up the extra 20%. That's the total together. So Medicare is 1,600, 1,500.
Okay, so and then they have maybe a supplemental insurance as well?
Exactly.
Okay.
And so when I submit to Medicare, I submit it with everything, and then it goes, it goes to Medicare, and then it goes from them, it goes right to the medical carrier. And that's the only experience I have, but with the group that's here, how many of you place implants? Okay, so we got more than half the people. Okay, good. Okay.
So, and with implants, just so you know, with implants, there are many carriers, well, I shouldn't say many, there are carriers that do not cover implants. Blue Cross Blue Shield, where I live here, they exclude implants from their policies. That be on a global level. That being said, I've seen many implants covered here. It's going to come down to the quality of the patient's policy and if that is a covered benefit. But a lot of what I was showing you for grafting, well, no, those were more, well, the $9,500 grafting was from here.
Mhm.
So from that same carrier.
Grafting, but not implant placement.
That was just grafting.
Yeah.
So you have a lot of wiggle room to potentially build that implant into your grafting fee in situations like that. But, again, every patient, even within a carrier, one plan might have better benefits than another plan. They may pay more than another plan. So it can be different per plan and per group. So, and the reason they don't, and the reason why some of these carriers don't pay for implants is because.
Oh,
Yep.
There's a question.
How do you charge patient for the copay?
How do you bill out the patient?
How do you charge patient?
How do you, well, that's also going to be dependent on if you're billing it to dental too. Because if you are in network with dental and not with medical, if you have a copay that comes through on the medical side and you're contracted on the dental side, you have to follow the dental contract and you won't be able to collect the copay or deductible. That can get into a complicated.
I don't think she followed you on that.
Charged by medical or dental?
Are you just, well, there's a lot of scenarios that can happen with that. Are you just charging to medical? And how do you collect the co-insurance from medical? Is that what you're asking?
Yes,
You would just, you wouldn't know that up front. You likely, you will have an idea of what their benefits are. And you could collect that up front, just as you do with dental.
is that just us
Um,
analyzing their medical policy?
is that what?
How do we have them get the idea on what their coverages are?
Yes, yes,
So we have to basically educate ourselves on what their medicine, what their medical coverage covers.
right.
That's why you have her.
That's
You were
probably
the-
the hard, that's probably the
the hard.
hardest part.
You were the hard
That's
one.
probably the hardest part.
Yeah.
So, yes. So financial arrangements are financial arrangements. This is if you don't have good ones in place, this is when you beef them up. And if you can't, our goal is to be the solution for the patient, and offering the financial arrangements through Care Credit or, different places that can supply the so that you're not the bank, can supply the money, the fees that need to be collected, so that you don't end up being the bank in all of this. So your financial arrangements are your financial arrangements. Your fees are your fees.
Yeah.
So here,
Sending out the medical.
can you say that again?
I said, don't jack up your fees just because you're sending it to medical.
Well, you can't. So here, that's a good point. You can't go, okay, well, I'm sending it to dental, so I'm only going to send $50, and I'm going to send the same patient, the same service to medical, and I'm going to submit it for 100. You can't do that. It has to be the same. And this is part of why I do what I do. There's a lot of companies out there for sleep that are doing just that. That's fraudulent, and your NPI number is attached to that.
So you're basically saying if you're submitting to dental and to medical, it's got to be the same fees.
Yes, and if it's, and so,
It
and
could be whatever fee
these,
you come up with. It could be whatever fee you
yes,
come up with, but it has to be the
Yes.
same thing.
Yeah, but they're not linear codes in some cases.
No, but your total.
Oh,
So like if the total dental implant was, or the graft was $800, but breaking it down medically, that could come out to 4 different codes that total that $800. Does that sound right?
well, we're getting into the total case. I don't really want to go down that path, because it gets complicated.
Okay.
It can get complicated. You can do a total case fee and break it down, yes. But here is that if you go into dental economics in April, I did an article where I really compared, this is the same insurance policy, dental in-network, medical in-network, and what they will pay. And it was 2 to 12 times higher reimbursement than dental by submitting the same exact things to medical. So look that up on dental economics, or actually, if you go to my website, you'll see it in the resources page as well. It'll bring you right to the link. All right. Here's another thing to think about. And this is a surgical, thought process. And, your eval, pan, CT times 3, your repeat CTs, all of that stuff added up. There's a big difference in what is being paid on the medical side versus dental. But the whole thing about that is, on the dental, the dental side, they're typically not going to pay for the extra evaluations or the extra pan if they're not in the frequency that they demand. And CT, they typically don't pay for, and they typically don't pay for grafts either. So there's a whole bunch there that potentially doesn't even add up to the $8,096 paid by dental. Even if it did, if they only have $1,000 benefit, that's all out of pocket for the patient. So ROI, just showing you the ROI here. It's huge. But we've got to start thinking as we're medical providers, and we've got to start valuing our worth. That's half the battle right there. So why would we think about billing to medical? Increasing profitability, increasing case acceptance, decreasing patient out of pocket, saving dental benefits for teeth related problems, or, you know, things that need to be taken care of with the teeth. Significant ROI, if you know what you're doing. I get a lot of practices. I talked to one earlier today, and they're like, we've tried this, it just didn't work, you know. I'm like, I totally get it. I hear that all day, every day. So it's really having somebody that can help support you in the process. There should be nothing that you should have to flounder through. And getting the mindset that you should be paid as a medical specialist. So hopefully I was able to give you some thoughts and some reasons as to why would you restrict yourself to just dental insurance and benefits. It shouldn't say insurance, it should say benefits.
Yeah.
And again, you know, what is your why? I have my why, but why would you want to do it? You know, really getting set on your goals of why you want to do this. We're going to have to change our approach multiple times. Every practice is different. Every philosophy of a doctor is different. And so, you know, that's the customization that we offer is it has to be, because I want you to feel comfortable with what you're doing. Again, I showed you a lot of stuff. I showed you a lot of different fees, but it doesn't mean that that's what you have to charge. And when you look at bone grafting, one site versus a whole quadrant is it should be a very different fee. So there is room for more of a sliding scale structure than in utilizing dental benefits. So knowing your why and being willing to be coached and being willing to change your approach to never give up what your goals are with this process. My goal is to continue to close that gap between medical and dental. Working hard on it, and even our mindset, closing the gap on our mindset that we are truly dental. We're dental providers, but we are medical specialists. We are oral physicians. We're oral practitioners, whatever you want to call yourself. Even on your website, shouldn't be meet the dentist, meet your oral physician. Market it as that. Get people thinking different.
So I'm sorry.
Our goal is to really optimize that customized approach in tandem with our practices to ensure your success. That's where we come from. Our goal is your success. Here's Carry Free. If you want to learn anything more about them, you can grab that QR code. They'll send you a free book. Their risk assessment forms. You can get, you know, CE for a webinar on, you know, infectious carious lesions and how to prevent them. They're not going to put you out of business. Don't worry. There's always going to be plenty to go around. So I want to thank you guys for your time tonight. Again, it's been a pleasure being here, and I'll certainly stay as long as you guys want to answer any more questions. Here is my QR code if you want to reach out to me. I do offer a medical billing analysis, an MBA. And basically that is just looking at your numbers, identifying what in your practice qualifies for medical billing and what opportunities you have. So if that's something that you're interested in, feel free to reach out to me. That QR code is the best way. Otherwise, you can send me a direct email as well.
What I might do, hold on with that screen, is
Also, if anybody wants, I believe Larry recorded this entire presentation.
yeah, and so I just kind of bookmarked what your QR code and everything. So what I may do, if I can get it to work properly, is when we send out our follow-up email, I'll put that link in the email. So that way.
I can send it to you too, if you want it.
But that'd be perfect. Anything you can do that way would be great. Usually, I'm gonna try to get it within the week. I send out a follow-up email with all the CE and everything. So my next question for you is, as a TIPS medical billing company, you work with the dental staff to educate the dental staff on how to go about medical billing top to bottom, correct?
Yeah, exactly.
In doing that, I know that there were a lot of different, I'll say forms that you've come up with that you have seen that work for documentation purposes. When you come into an office, is that something that you customize for the office?
Yeah, we start with what I have, and if, you know, if you want to take stuff off or add stuff, that's always customizable.
Okay,
But most practices don't even know what they don't know. So, you know, we start with what I have and then we change it as we go.
other than what you've gone over with implants, with oral infections, with replacements, what do you find reimbursements for, say, easier with, I said before, sleep apnea or occlusal bars or any other oral appliance that we make? Do you find, insurance companies going with that? Also, what about ortho for a malalignment occlusion? Is that something that medical can cover?
When you get into ortho, it's going to be about not so much the teeth and the alignment of the teeth, but you're going to be looking at potential airway, and anytime that you're doing expansion, that's when they're going to be looking at potentially reimbursing for ortho. So again, take the teeth out of the equation. If you've got to change the skeleton, then there's going to be potential opportunity to go to medical. But again, that's going to be based on the patient's policy and how the medical policy is written for that carrier.
Okay.
One thing I forgot to mention, you guys, in New Jersey, you guys have a payer there that will not pay a dentist for a CT. Okay. Total discrimination against our provider type, but it's me fighting them on that, and that's not going to work. What I would suggest in New Jersey is that you set yourself up as an imaging center within your practice, which you can do. You have to have a different tax ID and NPI, and then it's billed as your imaging center and not as the dentist. So just an FYI.
Interesting. It's skirting it. It's like an end around.
It would be Blue Cross Blue Shield. That is, or your Horizon. That is
they're wonderful to deal with.
Yeah.
What about restoration of caries? I'm trying to think of the right word because I think it's word tooth. Restoring teeth, for lack of any other.
Well, again, with any type of restoration, or any type of root canal or any type of crown, for any type of systemic condition that the restorations need to be done, there is only one code that we have for that, and it's an unspecified code, and it's going to need explanation, and it's going to go through medical review and it's just gonna depend on how they review it and who the reviewer is. I mean, if you get a podiatrist, pretty good chance that they'll say yes. If you get an ENT or a dentist, they may go, no. And it's gonna depend on what they think.
Next question was, what about restoring vertical dimension? No. Okay. Unless you're, okay, as a dental.
Remember, they really don't care about teeth.
Yeah, okay.
You remember, just think in your mind, think of Jack with all the jacked up teeth
Yeah.
that he had.
Yes.
Yeah, I mean, get past the teeth.
Okay. Okay, we're getting noisy here now. Condra, I want to thank you very much
Yeah, absolutely.
for everything.
Hopefully I shedded some light on some things.
I think so. I think so.
It was a pleasure.
Let's put it this way, no one got up till the end.
Oh,
No
good.
one-
Good.
So I want to thank
All
you
right.
again.
You're welcome. Have a great evening.